She will be highlighting about the role of ultrasound biomicroscopy. She is a chief consultant at iVision Eye Hospital, Thrissur.
So the talk on ASOCT was very illustrative and very useful. And coming to comparison between UBM, I thought UBM was also interesting topic. Hope actually those people also have gone. So we'll start off. Okay. So anyway, so what is basically UBM? UBM again is a imaging technique, high resolution ultrasound technique. It is non-invasive in vivo imaging. So it is like a, it gives near light microscopic level of imaging clarity. So UBM was developed by Pavlin, Scherer and Foster. It was in the late 1980s only it was developed. So this is how the UBM looks like. It has a probe, a screen, and it is done with a water immersion. So it has silicone cups, and this is how the between the B scan and the UBM, the frequency is different. It is like with high frequency when compared to a B scan, and hence because of the high frequency, the depth of penetration is just 4 to 5 millimeter, and you are able to image only that much of depth. The principle is similar to the B scan imaging. High frequency transducer is made, which is made of piezoelectric polymer, is moved linearly over the imaging field, and the transducer transforms the electrical energy into acoustic energy and vice versa. So this is how the parts are there. This is the water bath, water immersion that is used, which is kept onto the eye like this, and onto this, after filling the water, this transducer is kept and imaging is done. And this is how the image looks like. So we have transverse cut and the radial sections. Radial section is when you keep when the patient looks directly onto the ceiling and you keep the UBM probe onto the cornea. When it is 3 o'clock to 6 o'clock, you get like this, and 12 o'clock to 6 o'clock you keep, and then many clock hours you can keep. You have at the end of the probe one white marking, and this white marking will be onto the image on the side will be onto the right side of the screen. Here the right side of the screen will be the white mark, and when the transverse imaging is onto the limbus. So when you keep the probe onto the limbus, the transverse image happens, and transverse image is usually to identify the ciliary process and beyond. So the probe orientation is the white mark will be on the right side. Normal ocular structures needs to be identified, as Dr. Jaini has correctly mentioned. The identification of the structures posterior to the pigmented iris layer is what is most important in UBM. This is what is most crucial in identifying secondary angle closure. That is where UBM is most important. We can identify that the angle is closed. For that, ASOCT may not be required. We can identify otherwise also. But what is the reason for this secondary angle closure? When you need to identify that, you need to see what the ciliary body is, what is the relation of the posterior chamber, what is the relation of the lens and the iris, and how is the ciliary body and the choroid acting. So that can be identified based on this. So we are able to not just identify glaucoma. It is useful in tumors, traumas, identifying scleral structure, sclera, layers of sclera, cornea, in identification of ICL, and identification of placing of the IOL, and ocular adnexa assessment also. So what is some role of UBM is there also in open angle glaucoma. Even if I have told mostly in the secondary angle closure, the UBM is useful predominantly in pigmentary glaucoma. We know that pigmentary glaucoma has reverse pupillary block. Because of this posterior bowing, what happens is these sonules can be clearly seen in UBM. These sonules will rub against the posterior aspect of the iris, and this releases the pigments, and PI definitely helps in this pigmentary glaucoma. So at least in the before severe pressure increases happens, if you do a PI, this reverse pupillary block goes off and the patients are relieved of pupillary block, reverse pupillary block, and it is the treatment. So it definitely helps and you can do it. And when IOL is in the sulcus and the haptic rub, that is when one piece IOL is kept in the sulcus and not in the bag, this haptic can rub against the posterior iris pigments and release pigments, and this can lead to what is called UGH syndrome also. So if the pigments are there and the pressure is not coming down, you can always look at the relation, and if you see this, you have to take the IOL or dial back into the, if it is an early case, you can dial back. Closed angle glaucoma, all the types of pupillary block can be identified, plateau iris can be identified, anterior synechia, ciliochoroidal effusion, malignant glaucoma. To identify malignant glaucoma, you need to have an UBM and cystic angle closure. So this is a condition of phakic pupillary block. What are the things that you can make out in this case? So I'll suggest something. This is a anteriorly subluxated lens. What else is there? Anything peculiar with the lens? It is a microspherophakia. Can you make out? The lens is spherical. The lens is small. So it is a microspherophakia. What about the zonule? Do you see a wavy nature of the zonule? The zonule is weak and some areas it is broken. So it has a broken zonule and that is the reason it has anteriorly subluxated. So doing a PA, it will fall back. Okay, this is what pseudophakic pupillary block. And how do you this patient was referred 6 weeks after cataract surgery with severe pain, headache, vomiting and all, and referred as a malignant glaucoma. So the treatment, I mean, in malignant glaucoma also you end up doing a PI and try to hit the posterior aspect and vitreal, hit the hyaloidotomy, trying through the PI only with the laser initially. But even then, the treatment may not be sufficient with malignant glaucoma, sufficient at that point of time. But how do you differentiate it? By UBM alone. This here is one crucial step is there to identify whether it is pseudophakic pupillary block or malignant glaucoma. This is this angle, the pupil and the iris ciliary body angle. If this angle is maintained, it is always pseudophakic pupillary block. If this angle is not maintained, it is malignant glaucoma. Always look for this angle, and that is the catch point, nothing else. And doing a PA, immediately this falls back, all the pressure, you don't have to give any other medicine. Take the patient immediately to the PA, the pain is relieved. This is plateau iris configuration. What you see, closed angle and the ciliary body is apposition. But this patient is not in pain or not in an emergency, because this is a normal case coming with an angle closure. So, why this PI? When you do PI in plateau iris, it is not going back because the posterior iris is supported by the anteriorly rotated ciliary body. So, it is never going to fall back. What helps in plateau iris is the peripheral iris constriction by iridoplasty. This is an anterior synechia. So secondary angle closure, Dr. Jaini has mentioned, no? So you can see the secondary angle closure, angle is closed and ciliary body effusion. And when you do the transverse section as told, no, that from the limbus, if you recede back, what you see is like this much of choroidal effusion. That patchy sponge-like area you are able to make out, no? That is the choroidal effusion. So once you stop that inciting drug, all this goes off. Let me just tell you one thing. The most important sign or most important thing that should give you the diagnosis of a secondary angle closure is the myopic shift. If nothing else is also there, nothing else is there, if the myopic shift is there, that is sufficient to make a diagnosis of drug-induced secondary angle closure, the drug-induced thing. And this is at presentation where you can see this is closed, and here again the ciliary sulcus is not there, choroidal effusion is there. So once the treatment is over, what you can see is that the angle has opened up, and at one point you can make out that ciliary sulcus would have come and the choroidal effusion has gone off. One of the maybe and malignant glaucoma, as I'll show the picture directly. This is how a malignant glaucoma looks like. Again, the AC is very shallow. Usually in malignant glaucoma, even the center portion becomes very shallow, and you cannot identify the ciliary body as a separate structure. Even because it is the posterior pushing from the vitreous, and the ciliary body also goes and gets plastered onto the iris, and everything as a whole unit goes and gets plastered onto the cornea. So this is a case where exudation has happened in the iris, and this is an endophthalmitis, endogenous endophthalmitis, and on treatment this iris exudate has cleared. So in trauma, what is this? This is a case of iridodialysis. The iris has come from the iris root has given off. So why is this iris root gives off after trauma? It is because it is the thinnest area near the root. There will be a small stump which is remaining at the scleral spur. So this is again angle recession. Angle recession is where the both layers separates, and this is how the schematic diagram shows. Here this is the scleral spur, and this is the attachment of the ciliary body. And angle recession is like this. The two layers get separated. So here the two layers are separated. The ciliary body is still attached at the scleral spur. This is the normal one. This is what? This is cleft where it has detached. So you can see a cleft here, the gap. So that is the cyclodialysis cleft. So it is important to identifying the anterior portion of the cyclodialysis cleft is possible in ASOCT. If you move the eye and take the ASOCT, you can see some extent of the cyclodialysis cleft in ASOCT. But it is important to do the UBM in cyclodialysis cleft, because it is very important to identify the extent of cyclodialysis cleft, also to see the effusion, the fluid that is there. Sometimes what happens, gonioscopy also might be little dicey, in the sense like the anterior portions, some portion will be covered with PAS, and behind that cyclodialysis will be there. So it is very important to do an UBM, especially post trauma if you have hypotony, even post surgery also. So to see the extent of iris cyst, here whether the iris cyst is extending onto the ciliary body also can be seen. Evaluation of bleb morphology. Ideally, bleb morphology is not done with UBM. It is best done with the ASOCT, because ASOCT you don't have to have a contact method, and the details, the resolution is always better with an ASOCT than the UBM. So the perfect details will be seen on the ASOCT, and you don't have to touch. We are always worried about touching the bleb. And immediate post-op also you can do the ASOCT on a ASOCT bleb. Again, post AGV, the same thing. Here the AGV, it is a opaque cornea. So here the ASOCT may not be that useful, but even if you say ASOCT is done in clear cornea, some amount of opacity the ASOCT gets through. And here what you see is the valve is not reaching onto the tube is not reaching onto the anterior chamber, and that is the reason why the pressure might be elevated. This one is already highlighted the difference. The most and the important difference is the visualization behind the pigment epithelium. And the other limitation, the lying position cannot be done, and this contact procedure and contamination risk, everything can be reduced by using what is called as a clear scan. Clear scan is a fluid filled chamber that can be attached onto the UBM probe. So the patient need not always be made to lie down. You need not use the same probe. You can cover the probe, so the risk of contamination will be way less when you use the clear scan. But it costs around 1,000 rupees for that clear scan cover itself. So these are the textbook you can refer. And thank you. Hope it was useful.